Why's that then?
Unfortunately.
Sorry?
It's just a quirk of how I log in. I've got a...
Oh, okay. That's all right.
Yeah.
Well, let's start. I think Julian will be here in a minute. We're at 10 o'clock. Okay. Welcome, everyone. Any public questions been submitted, Julie?
No.
Okay.
And we've got no apologies.
Okay. And declarations of any other business for the meeting? Declarations of interest? Minutes of the meeting of 11th of July. Any corrections, please? Okay. Action log and matters arising. When I've gone through it, everything's either done or in hand. I don't think there's anything outstanding unless anyone wants to raise anything. Okay. So move on to item 6 then. Now we were going to have a patient story, but unfortunately the person concerned has had to go off to support an urgent operation somewhere, I think, Debbie, and so we'll have to postpone that to another day.
Yeah, I'm really sorry about that. They'd confirmed yesterday and then contacted me at 9:15 this morning, so it was a bit late to ask somebody else to step in and do a different story at that short notice. But they've been called away as an urgent clinical matter.
Thanks for that, Debbie. Well, we've got a fairly busy meeting actually, so we can use the time productively. So 6.1 patient experience quarterly report, Debbie.
Okay, so this is the first time that I've produced the report in this summary format from the board as requested, so it'll be helpful to have and I would appreciate some feedback really to see if it's doing what you're hoping it would do for you in the board papers. I'm hoping it's self-explanatory. The full papers are in the board pack and linked to the agenda for those that wanted to read it all. I just wanted to say the first table, which has got arrows in it, that is just to show where we are in relation to where we were in Q4, because I thought that would give a bit of context given that this is a Q1 report, and where possible I've either put in targets or last year's totals as well into that table so that you can have a little bit of context, because I know often people say, you know, how many is a good number of MP concerns, for example. There isn't really a good number or a bad number because all feedback is important, but it is helpful to know how we're doing in context of previous years, I think. Okay. The patient experience team have been working really hard with divisions where they've got large footfall and lower feedback to improve that, and that is one of their quality improvement programs. So I'm hoping we will start to see that reflective. Children's services particularly still have quite a low response to the patient to the new patient survey. Other than that, I was just going to, from a demographic perspective, it's quite interesting. Men just as likely to make a formal complaint as women, but less likely to fill out the patient survey. So when we're looking at how we gather feedback differently at Prospect Park, I think that's definitely worth taking into account. White British appear much more likely to make a formal complaint. However, the completion of the survey for all demographic groups is more aligned with the footfall. So it looks like people are generally across the ethnicity groups filling out the survey. It's only a guide because we do still have a number of patients who choose not to let us know their ethnicity, less so for formal complaints, interestingly enough, but it does give us a rough guide. And other than that, I'm really happy to take any questions. The full paper has on pages 15 to 17 the You Said We Did, which I know people are really interested always to see, and people are starting to use that actually in terms of raising tickets. So if a person has raised something, the patient has raised something within the review of the I Want Great Care tool, that is being generated as a ticket into their huddle board and looked at with staff around how they might make improvements. So it's good to see that join up between the feedback and the quality improvements starting to take shape. Fair to say that some services are more advanced with that than others, but it is a work in progress, which is a good step to see.
Debbie, thank you very much. Any questions from colleagues? Sally.
It's good to see, Debbie, the real-time feedback, you know, that colleagues, frontline colleagues pick it up and do something and then can feed back to the service users. What I'd be really interested in actually is this idea of alternative ways of capturing patient experience for Prospect Park, you know, the mental health patients at Prospect Park, because they're a big group, but they don't always fill in the experience forms, do they? So I'd be very interested to, you know, hear about the developments and thoughts around that, and whether there's good practice elsewhere that we could sort of capture. I don't know.
Are using, so they have community groups where the patients come together with either a peer support worker or someone, quite often the psychological therapies and the assistant psychology staff do those groups. What I haven't done at the moment is manage to get that into some format that would go into this report, as opposed to it not happening. So
Yes.
so that is a work in progress, but
Right.
it's not so that they are not hearing the patient
No.
voice from a different route.
No, I understand that. Thanks very much.
Thank you. And Mark.
Yeah, morning, Debbie. Debbie, at the bottom of page 53, I was a little bit confused to read that where we receive
Are
a
you in the
score
full
of-
papers? Sorry,
Yes,
I
the
just
full-
need to
sorry,
switch
the
to the
full
full
papers.
papers then. Hang on, bear with me a minute.
That's okay. If I just give you the background, it's where
Yeah.
we're receiving a
I've got
low rating of only 1, and yet we're receiving positive comments. The feedback seems to be that this is also found in other trusts that are using a similar tool, but there's no intention to amend that. And it seems almost as if we could be getting some false feedback there. And I was just wondering why they were reluctant to change that.
Well, it's tiny numbers, and I guess whether you start with 1 being the highest or 5 being the positive, human error is going to mean that patients don't always read it quite right. What we can still do is pick up the positive comments. So that's how we know that they probably don't mean a low rating of 1. So if you go back to, say, the chart that's got the green and the red in the summary papers, which gives the positive themes and things. So we're still picking up things like that, even if someone has given us a score of 1. But it's not big numbers, Mark. It's just, obviously, if a service isn't getting much feedback anyway, because they're not promoting it highly for whatever reason, then that is more impactful in terms of their percentage overall positivity score than if you're getting hundreds a month, 1 or 2 that have misread isn't going to make a huge difference. If you're only getting 10, then one reading it wrong makes a huge difference. So I can see why there isn't a quick and natural fix for human error and people misreading things all the time.
Okay, and is that your understanding with the other trusts who are experiencing the same? Yeah. It is. Okay, thank you.
Thanks for that, Mark. I suppose I might come onto it later, but it might be one of these sort of human factors issues that I quite often, if I do these surveys, which is not actually very often, if it's a numbered one, you know, is 5 good or is 5 bad? And even though it says it in black and white just above the table, you click on, I still sometimes get it wrong. So I think some of these things just happen, a bit of the design of the psychology of the table. The overall thing, Debbie, is that things are pretty steady. Is that we take from the report?
Yes, there's not huge amounts of difference in terms of, the services that are getting more MP inquiries and concerns are similar to previous. And we know that we've got, big pieces of work going on around neurodiversity, for example, which generates by far and away the most MP concerns and has done for quite a period of time. So no, there's nothing that jumps out at me that is different from previous quarters.
And just in terms of the learning, you said we did type learning. These things will come up in a very local service, won't they? In a particular service or part of a service. What's the process for capturing those? Because they may be common themes across the whole trust as opposed to particular to one service. Is there a process for how that's collected up and then actions at a wider scale if necessary?
So each of the three, so now that we're into 3 divisions from a mental health, physical health and children and all age, those themes are talked about in their meetings at divisional level. So they're not just kept at an individual service level. These things are talked about there. They also, so the report goes to QPEG and it goes to the divisions, so everybody can actually see what others have done as well. So, and of course the divisions, and Tamina will be able to tell you more about this than me, but the divisions and the clinical directors opportunity for people to share across in informal and formal ways.
Okay, Debbie, thank you. Naomi.
Yeah, thanks, Debbie. Just a quick one on complaints. I'm just interested in kind of almost our anticipation of those. And this is you know, the response here is going to be kind of broad, I'm sure, because it will depend. But before a complaint, generally speaking, before complaints arrive, are we in anticipation of them? In other words, do we know that something has occurred which is likely to result in a complaint, and therefore action has already started or is in play before the complaint arrives? I know that's a tricky one, but I just, you know, it's always nice to think that we might be ahead of these things.
Yeah, and you're absolutely right. So quite often, not always, sometimes a complaint might come out of the blue, but quite often there has been informal work, meetings, resolution attempted before a formal complaint comes in. That doesn't always happen. Some of our cohorts of patients are more likely to be letting us know than others that they are going to put pen to paper. And of course, we do have to remember that around 50% of our complaints are not upheld generally. So those that have substance, we would often know were a concern, and people would have been trying to resolve it. Most, not all the time, but a lot of the time.
Got it. Thanks.
Okay, thanks. Just on Debbie's second point, which is, thank Debbie for redrafting this paper to sort of fit in with a prototype, simpler format. How do you feel about the length of the paper and the style? Is it useful? Yeah. Okay. I thought it was thank you, Debbie. I think it was a good paper, and I think if we can try and gradually evolve so to have a paper like this for our substantive issues with a link to the data, if you want to get into the fine data, I think that'd be helpful. And I asked Debbie, which she's kindly done also, to put a little bit of text around the implications for EDI and the environment. Where I've looked at some of the EDI sort of scoring sheet, tick box type stuff we have on some, it doesn't seem to tell a very good story, and it's rather easy just to tick all the no effect on EDI, no effect on, just go through. And so I think a little bit of text actually written down helps give a bit of richness to the understanding of the implications for those matters. So if you're happy, we'll sort of follow a similar format and we'll see how it goes. Okay, Debbie, thank you very much for that. Quality Assurance Committee, Sally, you're going to lead us through?
Yes, of course. I'll take the minutes of the last meeting on the 29th of August as read, but just highlight a couple of issues that I know the board would want to hear about. One is the Never event. We have the governance around that it's obviously reviewed monthly at QPEG, but a report comes to the Quality Assurance Committee quarterly, and we had an update on that. I think from the point of view of the estates issue and the communication with the PFI partners, that's ongoing. But we did decide to invite the Director of Estates, Martin, to the next meeting and give him about 30 minutes to share with us what the actions that have been taken around dealing with some of the complex estates issues. But the rail itself, the replacement's now been accepted by NHSE, and there is a programme in place of replacement. It's obviously quite complex because it has to be done around patients. And I know myself from visiting Prospect Park over the last month or so, there's a plan in place on the wards to actually check the shower rails at regular intervals. The other issue that colleagues might be wish to have some feedback on is obviously the Regulation 28 report, Prevention of Future Deaths report that we had in June. And we had quite a lengthy discussion around that. The Regulation 28 was issued to us and Reading Local Authority, and I gather that we perhaps didn't at the Coroner's Court present perhaps as comprehensive overview of the actions that we've taken in relation to this young woman with a mild learning disability who was also in supported living, a very, very sad case. But you can see there the discussion we had. And we also received, and I'm mentioning this because it's been quite topical actually, and has been topical for a while, you know, the sexual safety report, although the assault on staff and patients, which includes physical and sexual. And we do seem to be having an increase in those sexual assaults, and the trust has responded to that and is going to do some more work in looking at although there's been a number of initiatives taken forward, they don't seem to be having the impact that, you know, we would want. The National Patient Safety Strategy Implementation Report, we're going to discuss that in part 2. Colleagues will have had an opportunity to read the minutes, and I'm happy to take questions.
Thank you, Sally. It looked as though it was a very fulsome meeting. A lot of important issues discussed there. Debbie.
I'd just like to clarify around the sexual safety, given this is an in-public board meeting. The increase that we are seeing is actually staff on patients, so staff having more verbal sexual assaults levied at them than we have seen previously. Well, I'll recorrect that actually. Staff are reporting more. We don't know if it's actually an increase or not, but I don't want people to go away thinking we're getting lots of physical sexual assaults on our wards and a significant increase in those because we're not. We are seeing an increase in the verbal assaults, and that is mainly against our staff and some patient on patient. And that is the work that we're doing to look at that.
Yeah, thanks for the clarification, Debbie. Well, we're going to do some further work around that. But it's been very topical recently, hasn't it, in the press with the sexual safety charter and things.
Could I just ask also, before you go on to the Guardian and safe working, etc., the suicide prevention
yes,
work that was reported and discussed? There's now going to be a new national, perhaps I'm looking at Debbie, I'm not sure, a new national initiative, is there not, on suicide reduction, Debbie?
Yes, and there's very recently in the last few days also been a toolkit for staff introduced from NHS England, which actually our staff have had quite a lot of involvement in supporting the production of that. So we're very lucky to have Sue McLaughlin in the organisation, I think, who takes a very active role in nationally as well as system and local initiatives around suicide reduction.
Yeah, there's a very comprehensive programme on suicide prevention, and we've just also recently, Debbie, appointed somebody who links with ED, haven't we, the emergency departments, and a person which is actually, you know, really good practice. So yeah, there is a lot of work done there, but unfortunately the figures have gone up to pre-COVID levels, but that's a national picture as well.
Okay. Any other questions on the substance of the meeting? No, there's some changes to the terms of reference. They look fairly minor, Sally.
Yeah. Do you want me to say anything, Martin, about the Learning from Deaths quarterly report? Because that's slightly topical over the last month as well.
I'm just going to do it in order, if you don't mind, Sally.
Right,
So on my agenda, I've got changes to committee terms of reference. Everyone
Right.
content?
Yeah,
Everyone's-
they're very
everyone's
minor.
content. Okay, let's move on then to Learning from Desk quarterly report, Sally, and then we'll go on to Guardian and Safe Working.
Right, the Learning from Desk quarterly report is obviously, I think there's a major focus on deaths across all NHS trusts in relation to the Lucy Letby trial, and you'll see in the minutes that we did have some discussion around that, and I think we're all left with the view of, you know, would we pick that up? What have we got in place? But I'm not, you can read in the minutes the discussion there. I'm not going to say that much now, because it's also in the subsequent Julian's paper, and we'll discuss it there. But you can see from our number of deaths in this first quarter that it's not excessive deaths. You can see there the numbers that were, you know, reported, closed, second stage, and then finally 5 were classified as serious incidents. And you can also see there the reviews that the second stage, the mortality review group have looked at 44. And unfortunately, but this is the pattern, a number of those, I think it's 15 of those, were from patients with a learning disability. So that's all I'm going to say now. The report isn't, it's in line with previous quarters, and I won't say any more now around, you know, would we pick up excessive deaths, because I know Julian's going to cover that in his paper.
Okay. Any questions on this, Sally? I just got one observation, which is perhaps Minion might comment on it. In page 101, the figure 1, the total deaths screened at first stage review is sort of declining year on year, which I suppose you can say is a good thing, or are we missing things? Is there an underlying causality of that, Minion?
I wouldn't draw any conclusions on reducing to say that we are doing better, because most of these deaths are end-of-life care deaths or deaths of elderly patients who may be unexpected deaths, but actually they were nearing the end of their lives.
Right.
So there will be variation from time to time. In fact, the 2021 figure is, in a sense, the after effect of COVID, and to a great extent 21, 22 also. So what we're seeing larger number there is actually the sensitivity of this to pick up large numbers, which is where we try to focus. The numbers are small. We are delighted, but I wouldn't draw a conclusion on that.
Okay, thanks for that, Minion. Mark.
Yeah, Sally's already touched on it, that in the Learning from Desk quarterly report, it mentions 5 classified as serious incidents requiring further investigation. I was just wondering, could somebody talk me through the process that those serious investigation reports are then subsequently scrutinised for us to seek assurance from?
Yeah, do you want me to come in there, Minu?
I can start the process and then Debbie hand it over to you, because Mark, this is an important question. So this is the nature of our current mortality review process, that in the first stage we look at all deaths. We don't try to differentiate, was this a suicide or was it an end-of-life care death? We look at everything. And then out of that, we filter out those which would be reported as serious incidents. So that's a separate report that you see, which comes from Debbie and the nursing directorate, which runs the patient safety team. And so I think this point is important. When you look at the figures, the total figures at the end, the serious incidents are only a tiny fraction of the whole mortality work we do. But the serious incidents are the ones where we have a particularly detailed focus on the reports, assurance. They go through legal checks, and of course, then they go to the coroner. So those are the serious incident deaths that I'm talking about. Of course, there are serious incidents which are not deaths necessarily also. So yes, it's a fraction which goes into the second phase of review under the patient safety team. Debbie, if you have anything to add there, please.
Yeah, just from an assurance perspective, Mark, the report is, so investigation is undertaken things that we're doing as serious incidents in the in-committee exec report for the board. We have a patient safety review meeting that Minu and I both sit on, where we read and see every serious incident report, whether that's a death or not, and often ask questions. Once that's been through that process, our serious incidents are also seen and scrutinised by the ICB. They go to the coroner and they also go to the CQC.
Okay. Thank you.
Okay. All right. Can we move on then to Guardians of Safe Working? Minnie, do you,
I was going to say that we received the report and which provided assurance, and there were no substantive issues this quarter 1.
very
I'm
good.
afraid there's nothing to report,
Okay.
Martin. There was 0 exception reports. I mean, we couldn't go lower than that, to be honest.
It's very reassuring. Thank you very much, Minnie, for what you do. Okay, Sally, thank you very much on those. We'll move on to the executive report. Julian, are you taking questions, or are you going to pick out anything? Questions?
No, Martin, I'll just pause and let people ask questions.
Okay. Any questions for Julian? I'm just wondering whether we might just have a brief update on the right care, right person. I know it's in the report, but are you able just to add anything to that?
Yeah, I mean, as I allude to in the report itself, there has obviously been concern among stakeholders because of the way in which it was reported, particularly in London, with the Metropolitan Police announcing without engaging with stakeholders. I have spoken twice now to the Chief Constable. Went to see him this time last week and spoke to him about a month ago too. Has a very different way of wanting to do this. Recognises in particular, Martin, that initial presentations are usually complicated, and what might appear to be a mental health issue may not be, and vice versa. So I feel philosophically, at least, that they're on the right page. I think it's right that we would recognise that the police are often held up in our 136 suite. So that's the biggest issue they probably have. We are, in terms of the calls and everything else, I think we're looking to get a standard operating procedure between the two of us so that we can be really clear when our staff make a call, that they've been really clear about the threat to life or, of the individual or to others. So that's clearly communicated to the control room. And then I expect over the next 6-9 months, we'll have to do some work on freeing up police officers. So at the moment, police officers are bringing people to Prospect Park in the 136 suite, and then there can be quite a wait in terms of the handover times. And that's the bit that I've linked in with Humberside about, and that's where effectively they've had to staff up, additional staff in Humberside. It's cost them nearly a sort of £1 million a year, so that it's not police officers, it's NHS staff who are looking after them. On the other hand, I've had a conversation with the police about the conversion rate, and notwithstanding what I just said earlier on, we are seeing police bringing ever greater numbers of people to the place of safety. But a good number of those, the disposition at the end of it is no significant involvement with mental health services. So those 10 officers that are getting trained up, and some continued good partnership work between the Trust and Thames Valley Police. We have a really good partnership, a local partnership. So Teresa Wiles, the divisional director, leads that, and our relationship is good. And so we are able to resolve issues quickly. And it feels like we're executing this sort of quite significant piece of work in the right way at the moment.
Yeah, it does sound to me as though good relations between us and the police is essential, because otherwise you can get sort of emotions get in the way, don't they? Particularly press headlines and things. So thank you for that. Sally. You're on mute, Sally.
Yeah, I just wanted to say, Julian, I am right in thinking, though, that the effective implementation of this would depend on quite substantive additional funds, because my understanding of Humberside, I mean, as you said, they did it over a number of years, didn't they? And there was a significant investment in it.
Correct, but I think we know where the cost is. I'll be honest with you as well, Sally. We've already been working towards a number of these issues with the police anyway. So some of the right care, right place stuff, Thames Valley Police and Berkshire Healthcare have already been sort of working towards. So there's a more of a perhaps a consensual view around this. As I say, the resource issue and the big sort of step will be the 136, and that's what we've got to work towards.
Yes.
And then we'll have to work with our commissioners as well around that, because obviously it's a cost that will effectively shunt quite rightly from the police to the health service.
Yes. Thank you.
Okay, anything else on the report? We've got a couple of things to agree. So the first one is about delegation of approval of the National Cost Collection submission to the Finance, Investment and Performance Committee. I assume, Paul, that you and Naomi are content. Okay, thank you. And the second is board approval for the staff vaccination programme requirements. And again, I'm sure we are content. And I believe there'll be a bus, our health bus will be at the 10th of October board meeting. So if we haven't already had it, we can have the board can have their vaccinations then.
Martin?
Yes, Julian.
Sorry, I did mean to say it is sort of buried away, but bearing in mind we've got our away day in October. My reading, I suppose, around item 8, which is the independent review of the NHS workforce plan, is, if you know, there's always a guesstimate. But if you take that at sort of reasonable face value, it looks eye-wateringly expensive given the sort of environment that we're operating in. And for me, it signals perhaps the importance of continued investments in sort of digital alternatives, and of course kind of research and looking for sort of breakthroughs, really, because trying to staff to that level at that cost and work with existing service models looks very challenging. And I think that there's no doubt about it, we'll see some more medical schools and all the rest of it, but it's going to be very challenging to fund this, certainly in the early years. And therefore, thinking about our buildings, thinking about our digital, and thinking about sort of breakthrough in terms of sort of treatment and also redesigning service models has got to be sort of pivotal in my head. And I just thought that would be quite a useful segue into next month's conversations, really.
Julian, thank you. You're quite right to highlight it. And I think we've discussed before, haven't we, the issue of, you know, how much more money can the public purse put into healthcare? And I think it's, with the other pressures, regardless of the politics of the situation, it's going to be difficult. So I think actually, in some sense, the silver lining of these difficulties is I think it does prompt you to really take alternative ways of delivering services, you know, genuine transformation much more seriously, because there isn't a, you know, we just wait a bit and hope more money falls on the table. So I think we will need to take this much more seriously. And I suppose the good news for this trust is that we have quite an open mindset on this, and we're some way down the road already. So, but I think you're right, absolutely right about that, Julian. Naomi.
Yeah, and I echo those comments as well, Martin. I guess my question is around context with regard to the ICSs, the ICBs, because I feel like that conversation which we will have, and I no doubt as a board we will have a, you know, granular and rich conversation around it, but I'd love to believe that the starting point is an understanding of where our two ICBs thinking resides, so that we can, you know, embed ourselves in that particular context. Do you agree, Martin? Sorry, Julian.
Yes, but I would say our ICBs on workforce would look to us to help shape that debate. So I think they'll be looking for us to say, okay, if that's the ask and the challenge, what do you think we might be able to do differently, given that we're closest to, you know, the services that are provided. You know, what is the opportunity? You know, what can virtual wards do? Because, you know, if you think about what's just happened with schools and the RAC issue, it seems highly improbable that capital budgets elsewhere won't be raided in order to sort of do. So you think about this sort of pincer movement. So it's got to be, you start to think about, okay, what are our service models that could be increased into people's homes that don't require kind of rebuilding of hospitals and structures and all the rest of it, and the digital. And I think that's for us, I think, to start to shape ICB thinking and help them with some of the challenges that they'll face at a macro level in terms of across a bigger geography. And so our board meeting, you know, informal discussion strategy session, I think will be really timely.
Yeah, and I, you know, probably just to repeat what you've just said, but in a slightly different way, Julian, it, you know, for me, the pivotal point of this is actually also about the allocation of resources, not just monetary, but people as well. So yeah, whilst the desire is to grow the amount of support and help and solution building, whether that's buildings or digital or people or money, we also have to debate and try to get a direction of travel for how the allocation of all that is going to shape up as we move through the next sort of 5 to 10 year period.
Yeah, absolutely. If we continue with the current shape, which is quite clear, which is, you know, the acutes have grown exponentially since 2019, then the change in service model won't happen. There won't be no headspace for it. So
Exactly.
You're absolutely right.
I think just before I invite Debbie, I think on this issue about ICBs, etc., my strong belief is that we as a trust are the people that deliver our services to our communities. And I think it is very much for us to, because of the closeness to how it works in reality, to come up with proposals and ideas about how to make it more efficient, more timely, whatever we're trying to do within the resources that, you know, in the end we have to work within. And I'm nervous about people, and I know you weren't implying this, but people who sort of wait for someone to tell us what to do. I think that's a very dangerous path. Because it'll just, everything will go into status and nothing will happen. So I think we just want to, I'm sure we'd all want the trust to continue to be innovative, to continue to develop these things. But, you know, perhaps I'm just old, but I'm a bit of a pessimist on the financial side. And I think we really have to work hard to find different ways of delivering the care that our communities need within the resources available, and not just assume that we can argue for a lot more, though there might be some rebalancing that needs to happen. Debbie.
I just thought before we moved off of the executive report, given the significance, we should just note that we have put the Lucy Letby response into this exec report. I'm just reflecting on the Never event comments when the Never event was in there, and obviously I know you'll have all read it, but we didn't then note it in the meeting notes. So I just thought it was worthy, but we know that it doesn't require a knee-jerk reaction. Boards are being asked to consider processes and policies, etc., in place, but I just thought it was worth us noting it for the minutes that we have all noted it. Sorry.
Thank you. No, thank you very much. And just on that issue, Minu and I went to NHS England meeting with the NHS executive and board, prompted by all sorts of things, but one of the issues was Lucy Letby, and there was a good discussion. And clearly some of these things, when we have to wait until the inquiry is complete and find, because, you know, again, press headlines don't always represent what comes out of the report at the end of the day. But the other theme that I think came out, and I hope Minu would agree with me, was that actually the underlying sort of issues that we're seeing are common across, like I say, all, it sounds awful to say a lot, but the other problems that NHS has had, you know, East Kent, Mid-Staffs, Morecambe, etc. And so we've got to be careful we don't focus on these dreadful events, but on one case, because the underlying issues might be the same issues in other awful events too. So we just need to wait until it happens. But I thought it was good for NHS England to call this together and to have had that open discussion. So it's very clearly in all our minds.
Martin, we got our managers week had our sort of quarterly session with our manager group. So we had nearly a couple of hundred people on Friday as well. So we had a good conversation. Sort of Minu and Debbie had put together just a slide, which sort of went through a little bit of what you said, which is, you know, think about that issue, but think about things that would attend to patient safety. And that's what we really addressed it as a patient safety overarching approach, which is, you know, what are the things we can do well and better around patient safety that would attend to you know, the wider challenges as you've indicated. And there was you know, some really good thoughts there. And we've got our senior leadership team session tomorrow evening. So that's all the people who report into exec directors again. We'll sort of pick that up, and we've got our all staff briefing in a week or so's time, and Minu will again sort of pick that up. So we just start to have that conversation in the organisation as well.
Thank you. And although there was quite a lot of formal process changes in response to LEPB and indeed other difficult situations, I think again the thing that comes across to me and is beginning to emerge more and more is about the culture of the organisations. That, you know, you need to worry about whether the culture is one which is open and, you know, wants to find out these things, are curious and wants to fix them. And no amount of bureaucracy, some of it of course is essential, but no amount of that will solve the problem if the culture is not right. I think that's the sort of theme that's came out of the Kirkup report into East Kent. So anyway, this is a rather sad issue to finish on, but I'm sure the trust, as Julian's indicated and Debbie, that taken this very seriously. Okay, if I haven't missed anything else out that I should have picked up, perhaps we could just move on. Performance, Paul.
Thanks, Martin. So to start with the financial position at the end of July, I think overall we'd probably summarise and say we're in a good and pretty stable position through the first part of the year. So surplus year to date of 100,000, which is $1 million better than we expected. We've got some detailed work to do over the next month or so on what the forecast is going to look like, because we do need to increase that run rate to deliver a 1.3 million surplus by the end of the year. But based on kind of high level numbers that we've looked at the moment, we're fairly confident we're going to hit the forecast before the end of the year. From an income position, elective recovery funding, reissued guidance and some numbers that have come out from the centre continuing to cause some confusion. So we're working through with ICB colleagues exactly what the impact is going to be for individual organisations. It's unlikely that that will hit our numbers until most likely in month 6 at the moment. So at the moment the position doesn't show anything on ERF beyond part year effect of the 4 million that we received from Bob. Pay positions kind of panning out in terms of a story at the moment year to date, which is we've got higher than anticipated levels of vacancies in our substantive positions. I think if you look at the chart on page 144, you'll see that substantive FTEs are actually lower at the end of July than they were entering the start of this financial year. Obviously that's creating a underspend which is being offset partly at the moment by unfunded Agenda for Change pay award pressure, which I think we've notified the board around, which we believe is going to be in the region of $1 million over the course of the full year. We're also seeing higher levels of temporary staffing spend. So spend on combined bank and agency is about $1 million higher than it was at this time last year, including increases for inflation. And I think that's increasing covering vacancies. We've got some medical staffing pressures in some of our services, and we've got higher nurse and HCA bank usage in mental health inpatient areas. That said, comparable to others, agency spend is still a relatively low level. We're still maintaining good controls over agency approvals, and spend is at 2.9% against the 3.7% cap. Non-pay is probably the other area to note. I think indicated out of area placements in July rose sharply due to kind of increases in pressure and flow at Prospect Park. So page 146 of the report, you'll see the average number of beds that we use rose from 19 to 34 in July, which was as high as I think any of us can remember, and increased costs in this area by £500,000 in that month alone. Just to kind of highlight the volatility, if you look at the bed report from yesterday, that number has dropped back down to 16. So I think we do see peaks and troughs. The current number at 6, so within the levels that we expected at this point in the year, which is good. Only other thing to note on the revenue position, which is going to continue through this year, is obviously given the level of cash that we have in the bank and the increased interest rates from Bank of England, we're showing about 600,000 of additional bank interest over and above what we planned. Like I said, expect with interest rates probably continuing at a similar level for the rest of this year, that we'll see that increase continue and play out in the forecast. Capital is broadly on plan. We're 300 behind a 1 million year-to-date position. No concern's been raised at this stage, and we expect that we'll fully spend our CDL allocation. And as indicated previously, cash is still in a healthy position. So I'm happy to pause there and take any questions.
Thank you, Paul. Any questions? Sally, you're on mute.
Paul, I noticed the out of area beds. It looked quite sort of it gone up quite high, up to 34. But I understand that a high proportion of those were forensic beds, and they wouldn't count. And I just wondered, I mean, whether there's something around the presentation of this where you put a bracket where you put the numbers that were forensic, because they don't add to the bottom line, do they? I don't know if it's not your area in one way in terms of what percentage were forensic, but
I'm not sure that's correct, but I'll let Tamina come in.
Right, perhaps I read somewhere else that it was a high proportion of forensic.
Tamina,
yeah. So I don't think what we're reflecting here is anything other than adult acute or PQ beds, to be honest. I suppose one of the things I did want to say is when it really tips up for us, that's reflective of pressure sort of regionally and nationally as well. So we have had days where there are no beds anywhere. I think the other thing that we want to start exploring is where we potentially have patients that aren't being accepted by people that we would expect to through our spot purchase or our sort of block contract of independent provider beds. There is a real challenge there, and we know that our teams are having to manage some quite complex patient and challenging patients within our PPH wards, particularly our PQ, where it's quite difficult to get engagement more widely to refer them on to a more appropriate setting for them. So there's two issues for me. One is the demand is high, and we're seeing that replicated across all of our other partner providers. And secondly, we still have this ongoing and increasing challenge around, I think, complexity of patients and where we could find an appropriate place for them. Some of whom may need a forensic bed, but for those patients where it's not entirely clear, that's where we begin to have some real issues.
Okay, thank you, Alex.
Morning, Paul. I think it'd be helpful for the board just to understand the context of our position within systems, and what that means in terms of us being slightly favourable at this stage and a healthy looking forecast, and B, what's happening in systems around financial position against plan and likely action through the last part of this year.
Yeah, no problem. So I won't quote specific numbers because I'm not clear what's gone to individual system boards at the moment, but it's safe to say nationally the financial position is looking extremely difficult, and there's a sizable actual deficit year to date, and panning out in terms of variance to plan. Both Bob and Frimley ICSs are both off plan at the moment. Bob is being driven fundamentally by the acute providers. Both us, but mental health and community providers are on track for plan year to date. NHSC have issued a number of financial and process controls that they expect all organisations to have in place and adhere to at the moment as a basic requirement. We reviewed the list and we're probably compliant with the vast majority of them. Some of the others we need to work through with the ICS in terms of how they're actually implemented. At the moment, let's say our position, you won't be surprised that obviously we have been asked if we can go further than we currently can expect to in terms of financial performance. I think given the numbers we've got at the moment are only month 4, it's very difficult to be able to make a view on that. I think we've still got some potential risks that come through. At the time of when we did the last forecast, we still had high levels of hopes. We've probably got a level of uncertainty over what the workforce numbers are going to look like over the course of this year, and we've still got winter to get through as well. So it's difficult at this stage to say that we would have any slack over and above the 1.3 surplus that we are expecting to deliver this financial year. But it is safe to say it is a very challenging position out there financially.
Thank you. Alex, did you want to add anything to that?
We know that the Frimley ICB particularly are looking at their financial sustainability and controls environment. I think it's kind of helped practical and pragmatic thinking to see that system is within a pack, if you like, of ICBs. ICS is going well over their planned submissions at the beginning of the year, as actually, frankly, we might have expected nationally, given the pressures. And so there's an important point coming up from the ICS particularly, and our input into the board's thinking around the rest of this financial year and the actions that may or may not be taken, and how that looks in terms of relative proportions of spend across the system, as we've just referenced in this meeting.
I think that, I mean, the thing to remember as well is obviously that there's a focus at the moment on issues that we weren't aware of or planning, or we did think were going to potentially be a risk this year. So agenda for change and medical pay award inflation compared to levels of funding. And I don't think it would be remiss to, if I was in the acute sector, certainly the direct costs of covering ongoing strike action is significantly impacting them, which wouldn't have been incorporated in any of their planning assumptions for the year ahead. So that's direct cost of covering, plus the fact that obviously that's putting additional pressure on them in terms of delivering waiting list targets, because that activity isn't being done and is being cancelled and is needing to probably be rebooked and delivered at a higher rate.
Okay, anything else on finance? Or can we move to performance, please?
Yeah, so I'll just highlight a couple of things out of the report. So in terms of the breakthrough objective self-harm incidents, obviously we're doing well, but July saw a small increase in terms of the numbers above the target. Probably the key thing to note there is the new focused area of work that the team are doing, looking at patients with autism and ADHD and the prevalence of those conditions within the number of patients who self-harm, and they're engaged closely with the neurodiversity team and are introducing a range of measures into the inpatient environment to try and see if they can alleviate some of the instances that we're seeing. We've got the new breakthrough objective this year around clinically ready for discharge, which obviously effectively is focusing on the wasted capacity, which again plays through in terms of the number of outpatient escalation beds that we need to put in place. You'll see from the numbers we've seen quite a steep and continuing increase in terms of the number of the bed days lost since January. Just to put that into some actual figures, so 12 patients in January increased to 37 in July, and that's an increase in terms of lost bed days from 269 to 712. So if you work that out over an average month, it's a number of beds that effectively are taken out of our system, as it were. Out of their replacements, no surprise given the conversation we've just had around the financial numbers, that we've breached target for out of their replacement numbers as at the end of July. On a positive, if we look at staff turnover, we continue to see staff turnover figures reducing, so down from 17% at the start of the calendar year to 14.3 currently. If we look at the level below that in terms of the divisions, all our divisions, so mental health, community, children, all age and corporate services, have all seen a reduction, and all of them are now below the 16% target. So community and mental health at just over 15%, children all age at 12%, and corporate at just close to 13%. So obviously that's really encouraging given our 3-year strategic aim to get that down to 12% overall. In terms of trackers, just one to highlight is audiology waiting times, which is on page 166 of the pack. Performance against this had dropped as low as 35%, but with some targeted recruitment and efforts of the team, they've now recovered that back, and we're performing back over the 95% target, which is really encouraging. And then finally, just page 165 of the pack, which is the one which is the most read of any of the pages, obviously continues to highlight some of the issues around our capacity and flow. So mental health, optimised patients ready for discharge, running at 21%, occupancy of acute and non-acute, both over target, and length of stay looking high, but obviously that's impacted by discharging long wait patients, which is one of the focused areas of work that we're doing. So it does present a slightly skewed picture. But the final point to note is just on the community health, medically optimised for discharge. Again, numbers are high at 28%. It's just worth noting this is starting to get a level of national recognition. So NHSE have only just recently published some data that shows across June and July, 88% of medically fit patients in community beds were not likely to be discharged, and that compared to 55% in acute. So it does highlight the individual pressures on community providers and the challenges with discharging and social care. So I'll leave it there and happy to take any questions.
Thank you, Paul. Good summary. Any questions? Tamina.
It's not so much a question, it's just building on what Paul was saying. It's been interesting being in conversations in Frimley and in Bob ICSs about our plans over the winter. In Bob, they've absolutely understood that we need to maintain a focus on community services and community discharge. In Frimley, trying to make that case has been a little trickier in terms of whether length of stay in the acute or length of stay in the community hospitals is more of an issue. And actually, when we look at a breakdown between East and West, the higher number of patients waiting for discharge are sitting in the East. So we know that's an area we need to do, partly in terms of the culture and expectations of getting flow through community hospitals and working with our local authority colleagues down there.
Thank you for that. I've just got one thing which isn't one of the things you mentioned, Paul. It's just about health visitors. When we seem to have a huge workload for our health visitors, could anyone give us a sort of a few words on that? Just to, I don't know whether it's you, Paul, or Tamina or Debbie. Who's going to volunteer to say something?
I can say a little bit. I mean, we know that we've got real challenges with our health visitor, which we deliver in 4 out of the 6 areas. And I think we've said that the tender for 0 to 19 is coming up in Bracknell imminently. In fact, we've just put our submission in. One of the issues we have is that we have this sort of we have a sort of 3-way contract in the West across the 3 local authorities. It's supposed to be a single contract, but doesn't really operate in that way. And we've done a lot of work, I think, with health visitors and the demand that we have over the last couple of years so that we can get back on top of some of our thresholds and targets. Talking to colleagues in Oxford Health, I think they've similarly got an issue and challenge around the demand for health visiting services. And we've put a number of things in place to make sure that we've got some safety netting for people who might be waiting for visits. I don't know if you've got anything more to say, Debbie, but I'm happy to go and get a more sort of up-to-date position, Martin, if that would be helpful just offline.
Well, perhaps we can take it later if it needs more detail. But my concern was just that when I read the reports, there's clearly a lot of demand, a lot of pressure on our health visitors in terms of the number of cases they have to do. And it's, an important from a risk point of view in terms of our communities. It's a very important risk. So I just wanted to make sure that, I'm sure we have, but make sure that we're doing what we can to not get ourselves pushed into a position where we can't cope and therefore health visitors, either take more sick because they're stressed or mistakes happen or whatever. It's getting that sort of balance right, isn't it? That's important. Okay, well, anyway, we can take that perhaps later, Tamina, but I just, it's one of the things I just worried about. Okay, just seeing where we are. Okay, now if we could then move on to strategy issues. The workforce, race equality and disability and the leadership strategy. So Alex, shall I hand over to you for this section?
Yeah, I'll introduce and we'll welcome Ash as well, who's authored these reports and particularly led on the leadership and management strategy. So the RES and WDES are the National Workforce Race Equality Standard Dataset and Workforce Disability Equality Standard Datasets. They're here for noting and to provide assurance and discussion points around our action and activity in relation to areas that we need to improve. Certainly on the RES, we're seeing some improvement across a number of the indicators this year, but it's against a number of years where we'd want to have made greater improvements. And indeed, the purpose of our anti-racism strategy is to be much more explicit around action orientation through the organisation to address this disparity in experience. Really pleasing to see representation strong and particularly in the board indicator. That's just a starting highlight really, and I'll ask Ash to bring any further highlights and we can take some questions and discussion on the first one, the RES.
Thanks, Alex. Good morning, everyone. Just a couple of key highlights to build on what Alex has said. I'll use language used set out in the RES technical guidance as well. So the number of our BME colleagues has increased by 99, so that's 1% more than last year. We have a workforce that's fairly representative of the Berkshire population, although not taking into account the working population. We still have around just under 3% of our workforce who haven't shared their ethnicity. So of course that could have a bit of a bearing on some of these indicators. But as Alex has said, we've seen positive change and improvement across 7 of the 9 indicators, with 1 staying the same and 1 moving in the wrong direction. However, the positive change hasn't removed the inequality in experience, so that's still our focus. The one where we've seen movement in the wrong direction is essentially our white colleagues are 1.44 times more likely to access CPD than our BME colleagues. So that's something we're already doing a bit of a deep dive into our data there to understand more. The one that stayed the same is our BME colleagues are just over 10% more likely to experience harassment, bullying or abuse from patients, relatives and the public than our white colleagues. And also the other point to mention is our white colleagues are up to 1.93 times more likely to progress in their career up through the organisation. So as Alex said, our next steps really are here in committing to becoming an anti-racist organisation. We are currently developing our actions in collaboration with our anti-racism task force, diversity steering group, and in co-production with our race equality network and our local community. So I will stop there.
Okay, any comments?
I think the sorry, just one more additional context piece. The race disparity ratio is interesting. There's a lot of red, but I'd note, although we need to improve our performance, actually we're fairly near the top of our ICS benchmarks and performing quite well in some areas. A lot more to do, but I think it's important to have the context as well, because we rightly as an organisation we're hard on ourselves and need to continue to be, but we're moving into a position where improvements will start to be noticed. Thank you.
Okay, Tamina.
Yes, so it's just a note of caution around the figure for the higher percentage of staff from diverse ethnic backgrounds being subject to assault and abuse. We just need to do a little bit more work on that, because we have a correlation which is it's more likely that staff will be abused and physically assaulted in PPH, and that's where we have a significantly higher percentage of staff from ethnically diverse backgrounds. So what I don't want us to do is make an immediate correlation that it's because of their ethnicity, although I recognise I think we do need to do some work on understanding how much of the abuse and assault has some sort of racial bias to it. So it's just a bit of caution about making some automatic assumptions on the basis of that particular statistic.
May I come back on that, Martin? Because I think it's a really well-made point about the dangers of aggregate data, and we need to understand within our divisions where this poor experience is happening. Prospect Park, we know there is racial abuse because we have correlated against incident data and from staff experience, and indeed that's where colleagues have set up advocacy support and post-incident support for racial abuse. But detail about where the poor experience is happening. And certainly our anti-racist approach will be engaging, connecting with divisions to highlight and understand where their particular hotspot areas are, as Prospect Park was one. Thanks.
Okay, thank you for that. I certainly agree with the need to be careful about aggregate data. So, okay, Sally.
Actually, one of my questions was along those lines. Ash, it's a really good report. Thank you very much. And I just wondered whether the different services do get the granular data and have action plans around what that data is saying about their specific services, because we do have differences across the trust. So we've obviously got high level action plans, but do the particular services also look at the data and have action plans in relation to what the data is saying for them?
Yes, I believe they do. So you probably be aware the RES and the WDES are split by workforce metrics and staff survey metrics, and these are shared with our HR business partners who work with our divisions on that data and share with them.
So who would take an overview around, if they're looking at the data and the specific themes, who would take the overview in terms of what their action plan is and what they're doing? Are you able to say, Ash, or perhaps I'd have an offline conversation with Jane or something?
Shall I just come in here? Just to say that would be the responsibility of the people partners, so the business partnering team, to talk to individual areas about action plans, and it will form part of their planning process, so their workforce planning processes.
Right, thank you, Jane. And my other comment was, I wondered whether it's more accurate to compare ourselves with other community and mental health trusts. Demography of say, for example, and I think we mentioned this in the report, the highest number of BME colleagues is in mental health nursing, or the highest number of BME doctors is in psychiatry. So it's a more accurate comparison if you compare with mental health and community trust. Would I be right in thinking that?
Without getting into the detail of everything, I think the two most similar trusts to us are Oxford Health and SABP. So if there's two that we really look more closely at, it is those two, because we're in the same similar geography, geographical areas. So I think it's still some use to see what's happening across the two ICSs, but I do agree, yeah, we have a slightly different workforce demographic.
Yeah, thank you very much.
Thanks, Sally. Naomi.
Thank you, Martin. Just actually words of encouragement in respect of the work or deep dive that you intend to do with regard to accessing non-mandatory training and continuous professional development. And but personally, I'd be really, really interested in the outcomes of that particular piece of work, because to some extent, not in its entirety, but to some extent, if we can get that right and improve it, I would love to believe that it would therefore follow that progressing through the organisation, which is another one of the disparity ratios, would also improve. There are other things that would contribute to that clearly, but I just think if you pull one lever to improve it, there's a good chance that another will improve likewise.
Okay.
And for those just to respond to them, for those in scope of our new leadership management programme, we need to be really careful and ensure we're making sure we get the right people going through that, because again, that's going to be a key driver to unlocking opportunity and retention and talent development in the organisation.
Thanks for raising it, Naomi. Julian.
Thanks, Martin. Just to follow up, so the other conversation I had with the Chief Constable last week was around violence towards staff, and that there's work to do. So you think about the concentration at Prospect Park Hospital and then who's impacted by this. There's a couple of things really for both organisations to work on. The first is for Berkshire Healthcare to be really clear when an assault has happened and to furnish the police with the right information, which is, most of those assaults are with people who've got capacity, but it seems to take us a long time to provide that information. And of course, it requires, witness statements. And we now have obviously really good CCTV, which we can furnish. The police have traditionally struggled with dealing with assaults that happen inside a psychiatric unit as opposed to outside. Exactly the same assault, exactly the same person with exactly the same levels of capacity has often befuddled more junior officers. And of course they're exactly the same thing, and it's for the magistrate or judge to determine whether there's any mitigation, and as part of the kind of right care, right person work, want to work with the police and ourselves. And they've committed to develop a bit of a standard operating procedure so that when an assault does happen and we're able to provide the information, they start to enact action quite quickly. And we know when that happens, it sends a message around that. So at the moment, there's a significant number of assaults that end up not getting prosecuted or reliant on trusts going through civil procedures, which wouldn't be necessary if it was outside the four walls of the hospital. So again, I think a really important piece of work where we can demonstrate working with the police to address what is clearly a very significant issue for our staff, but a disproportionate issue for our black staff.
Okay, thank you. There's a set of recommendations, Ash, you put at the end of your report, which I think I just want to draw to the attention of the board. It all look very, very sensible next steps. It's on page 186. These are ones that I guess, Ash, that you're passionate that we press on with. And just for the board, just to say that I've had some very helpful and informative discussions with Ash and his colleague Carla in this. So thank you very much for helping educate me on some of this. But I think this looks a good set of issues to go forward with, if we are content. Okay, can we go on then to the WDES? Disability.
Yes,
Alex?
so
Or Ash, yeah. Go ahead,
Ash, fine to carry on. Thanks.
Okay. Again, just a couple of points to really pull out. The number of disabled colleagues in the organisation has increased by 63 from last year, which is just under 6.5% of our overall workforce is represented in that category, compared to 5% last year. The data also shows that our disabled workforce is underrepresented by just under 7% compared to the overall Berkshire population, which is just over 13%. However, we don't have a clear indication of the disability status of the working population, so that's the overall population. Just to add to that, we still have a large number of the overall workforce, so over 8% who have not shared their disability status. So of course, this can impact on things within this report and disability pay gap and other work we're doing in this space to make things more better for our colleagues and our patients. So that's something we need to concentrate on. But on the whole, over the last 3, 4, 5 years, the number declaring is increasing year on year. So we're doing something to encourage people to share more. Overall, again, we've seen positive change and improvement across 8 of the 13 metrics. 4 have stayed the same and 1 has declined. So the one that's declined this year, it shows that our disabled colleagues are more likely to have felt pressure from their manager to come to work despite not feeling well enough. So that's obviously something we want to look into a bit more. In terms of performing well, though, I think it's also to share some of these. The relative likelihood of staff being appointed from shortlisting is 0.93. So that actually means that they're more likely to be shortlisted than non-disabled people. We've also, in both the RES and WDES, where we've made the most progress is the relative likelihood of staff entering the formal disciplinary process. So going, roughly from over 5 to 1.9 in that space. That's good progress being made. In terms of next steps on that one as well, we want to increase the disability disclosure rates, and we've started to do some work with medical colleagues, because particularly you'll see from the figures, nearly, I think it was 50% of medical colleagues haven't shared their status. We also, as I said, we need to investigate why our disabled colleagues feel more pressure from their manager to come to work despite not feeling well enough. And we also want to create that culture where our disabled staff feel safe, supported and valued, and reduce those number of incidents of harassment, bullying or abuse. So we'll be working with our staff networks and our Purple Network and Diversity Steering Group to focus on those problem statements.
Okay, any questions for Ash, comments? Rebecca.
Morning, thanks Ash for both reports. I thought they were really good. I was just looking at the one of the bullet points which talks about in particular the non-exec directors who've not declared their status, and I was just wondering whether given there's quite a small number of non-executive directors, we could sort of commit to do that, to show you know, leading by example, because it seems that some of the concentration around the bands 8C through to 9, which again are probably more senior, who are not declaring. Maybe if we can sort of lead by example, that might help.
Rebecca, thank you very much. I think we should all declare. I have to say, using ESR, which is electronic staff record, it's not the easiest process. And although I use it quite often for various things, I had to get advice and help from one of Jane's colleagues. And there is a lady whose name I've forgotten who's expert at this, and she guided me through to make sure I could update and correct my own one. So if you do get onto it, it might be useful contacting, and Jane can let us know the name of the lady afterwards, but just to get a bit of help, because it's a pretty Byzantine system, the ESR. But I agree absolutely with your statement, Rebecca, and I think we should commit. Thank you for that. Right, Aileen.
Hi, I think these are both really interesting reports, and we've made some great improvements in both areas, but obviously still much to do. I wondered if we've got any feedback about reasonable adjustments in terms of things that our disabled colleagues are asking us to do. I couldn't. It may be in there, but I couldn't find it in the report.
Ash, you able to?
Yes, I think it was. I'm just trying to find it from the report. It's around 80% of our colleagues feel that the trust is meeting the.
Yes, sorry, I must have skipped over that. I looked at it a couple of times. So that, I mean, that's good, but I would have thought that's an area that we would also want to improve on.
Yeah, absolutely is, because I'm thinking about those 20%. So it's around what we're doing in that place, our process, and we've brought it in at induction as well now to make sure that new colleagues starting are aware of our reasonable adjustments, and we're building it into our management development programs as well, so our managers know how to support colleagues. So we are doing work in that space.
Okay, excellent. Thank you. Thanks, Ash.
Jane.
Just to say, I'm not quite sure when this date is, the date I was trying to look, sorry, but I do think a number of on NEDs have, since the report was pulled together, have updated their ESR status. I've not checked, but if any of you still haven't and need some support, then the woman to speak to is Janet Downer. I know she's had a number of conversations with our NEDs to make sure that ESR data is brought up to date. So thank you for those who have done that.
Thank you, Jane. Naomi.
Yeah, just probably a statement of the blindingly obvious here, but if we make it hard for people to respond to the question about disability, then we can only expect the responses to be lower than we would like. So is there a way that we can improve upon the current system of that exists within ESI and make it easier for folks to respond And in that bundle there's the issue of definition. You know, the legal definition of disability can be a bit of a minefield and tricky for people to navigate. And so there might be something we can do to simplify and support folks to get the response that we require.
Okay, thanks for that, Naomi. Okay, and Ash, you will want us to support your next steps, I know, which we do. So thank you very much for that. So could we move on to leadership strategy?
Yeah, I'll just introduce this, Martin. So it's absolutely mission critical that we invest in our managers and leaders. And to be fair, there has been a lull in terms of our focus around this, which started in COVID and the drop off of our Excellent Manager programme, very successfully internally developed. I'm really pleased to bring forward to the board with the team here the refreshed leadership and management strategy and the subsequent programme, which you can see an outline of there, and the simplicity of the focus on self, your impact on others, and then your impact on the organisation and system that we work in. I just think are really three strong lenses within which Ash and the team have developed. And this has been developed with a leadership group and design team. So there's been great engagement and using our skills within the organisation across psychology, coaching, and core fundamental management skill sets that we need to support new managers into. So pleased to bring it here for the board to see, to note and approve as a really important step forward to support our strategy.
Okay,
Ash,
do you want to pick up some key things?
Yes, yeah, thank you. Thanks, Alex. Building what Alex said, in essence, our leaders, it feeds in quite nicely from what we've just talked about, those papers as well. So in essence, our leaders shape the culture we want, and this strategy provides the framework to which we'll nurture and grow the leadership we need for our culture. You'll see there we defined a vision. Our vision is for our leaders and managers to be highly competent, confident, accountable, and compassionate, inclusive. Our managers and leaders promote listening, learning, innovation, and continuous quality improvement. We need them to model our trust values and behaviours and lead our teams positively. Therefore, just to outline as well, the 5 key strategic priorities we're concentrating on, therefore, are developing our leadership and management capability and capacity in respect of that vision, building and embed our inclusive talent management approach, a more collaborative and holistic approach to developing high-performing teams, and to develop and increase our leadership diversity and commitment to becoming an anti-racist organisation. And the 5th one is around our support package for our managers and leaders as well. The role of a manager in health and social care is complex, so we need to ensure that support package and development for them is robust and quality as well. We are making good progress, as Alex has said, and we've just launched our new leadership and management programme, Leading for Impact, which focuses on those 3 modules: leading self, leading others, and leading in the organisation. But we've also pulled it together in a clear development pathway as well. So the first step would be Reaching My Potential, which is a pre-leadership and management programme focused on personal development and exploring yourself. And then you can go into the essential knowledge for managers, which is the managerial aspects relating to people, policy, procedures, budgets, and risk management, and so on. And then it's into those 3 modules of leadership. You'll also see we've got an implementation plan and an approach to evaluating the impact and difference this will make to our colleagues and patients. And as shared, it's been a gap for us. So leadership and management clearly has an impact on staff and patient experience from the data that we see. So we're pleased to kind of have movement in this area, and just wanted to update you on progress, really.
Thank you very much. Any comments, questions? Sally.
A very comprehensive report, Ash. One of the questions I've got, and it relates to the race equality report. Do we envisage putting together a specific programme for BME colleagues in terms of, because it's the 8B and above, isn't it, that we've got it, we're not getting a pipeline. and I know it's not unusual, is it, for trusts to have a particular programme for BME colleagues in terms of promotion? Is that I wasn't sure from the paper if that's what we've got in mind.
It might be something, Sally, that we look at. I think sometimes we have to be careful with these things, because sometimes sponsorship can feel like we're you know, it's more about giving our colleagues the opportunities, and I think that's part of our whole anti-racism approach. So sponsorship implies that they need something else or different than our other colleagues. So at times I think it's got to be the right thing and you know what our colleagues want as well. So I think we just have to be a little bit careful about those types of programs.
Right.
Sally, we have just to come back, we have had a programme like that in recent history called Making It Right, and I think there was some mixed feedback from colleagues that went through that. Why should they be highlighted as special?
Right.
And actually our approach around anti-racism particularly is about dismantling bias and discrimination within our systems, processes, and our approach to inclusion. So we want to drive equity, and that means we do this together. It doesn't have a special approach for particular groups. That's going to be challenging because there's a lot to unpack in that space. Yeah. But I'm confident because we've got 5 work streams outlined that are going to be led by executives for the anti-racism programme. And I think going to Rebecca's point in our July discussion around anti-racism, this top-down collective senior leadership around these work streams is going to be what's quite different for this approach around anti-racism. So hopefully that'll be an unlock.
Right. Thank you.
Mark.
Yeah, thanks for the report, Ash. I thought it was really well written. I was particularly pleased in terms of the way that all of the EDI initiatives have been woven into that, so it's an integral part. The question that I had for you, in terms of the 360-degree feedback that is being developed, it isn't already in place, and I do feel that all effective leadership management programs have that as an integral component so that people can have that feedback as they go through that journey. What timescales do you envisage that component being ready?
Yes, great question, Mark. So it is already in the programme, but we're using the National Leadership Academy 360. So that's already in as part of the programme. But we are recruiting some additional resource to help us develop some of this. So I'm hoping over the coming months that we can design that so it is Berkshire Healthcare specific.
That would be good. Thank you.
Thank you, Naomi.
Yeah, thanks, Ash. Really comprehensive paper and obviously a very comprehensive programme. My question is about the development of this. You know, I'm aware that corporations and organisations all over the globe have struggled and, you know, made progress in various quantities around management and leadership. And there are external agents out there who do this for a living, and some of them are extremely good at it. And many organisations ask those companies to come in and help them with this. So my question is, did we seek external help in order to design this?
Can I come in here, Naomi? Because I was more involved in the beginning of the genesis of this. The premise of this programme is that it is built around the compassionate leadership, and it's a build on what we have done before. And Deborah Lee, who has helped us to design that programme, actually lectures at University College London around that theme. So, but I have brought to that, I've had many years of management experience in my time. I've been to Warwick University, been to Lausanne, I've been to all of the sort of big name leadership houses for, you know, when I was at the civil service, for example. So I brought some of my learning into that in order to avoid the expense of having to bring in an expensive leadership development consultancy. And I think that where we've got to is, as you know, a good, you know, a really good leadership offer. Ash has likewise brought his own experience and background into this and fleshed it out into the detail that you've seen today. Okay. So I'm quite confident that what we're looking at is a really good piece of work looking at some of the leading thinking around where we are with leadership development, although we have managed to avoid the expense of bringing in one of the big consultancy groups.
Okay.
Could I just add, just also in addition to what Jane said, it's taken account of some of the national reviews into Messenger review and you know, some of the well-led domains from the CQC as well. So we have sort some of that external input into the development of the programme.
Thank you. Rebecca.
Hi, I was just picking up on Sally and Alex's point about the issues with sponsorship and sort of singling out particular groups. But just wondering, because I think there almost needs to be something that's quite subtle, but does focus and draw attention to those that perhaps aren't putting themselves forward for these programmes. And I don't know whether that's sort of looking at the pool of potential candidates and almost talent mapping. So saying, you know, these people at these levels, these bands, regardless of race and ethnicity, we would be wanting them to progress. And then if we look at that and find actually a certain group, particularly if they are Black and minority ethnic, aren't putting themselves forward, just being really proactive about on an individual case-by-case basis, encouraging them to go for these leadership and management programmes.
Ash, do you have a view, or Alex?
Yeah, absolutely. I think, and I'll share this with you, Martin, as well. I think one of the things we perhaps haven't done so well is equality impact assessment on some of our things. So I think having that lens where we're looking at you know, data experience and consultation engagement with lots of different groups of people, we can make sure then that things are truly inclusive. But I agree, there might be something subtle that comes out of it, and particularly if we're looking from a race perspective through the anti-racism work, the recruitment progression, that work stream might bring something out there as well that we may develop.
Yeah, so I think there's probably an intersectionality issue in terms of, you know, the race coupled with social mobility. You might find that there's a certain group of people who just naturally won't put themselves forward if they're from a lower socioeconomic background and also from an ethnic minority background. So almost just being more conscious of that for their managers, try and encourage them.
I think that's very wise advice, and we'll have a chance to talk a bit about succession planning in the next part of this meeting. So it might be something, Rebecca, you might wish to return to that. Rajiv.
Yeah, thanks, Martin. I just wanted to pick up on Naomi's comment and actually support what Jane said. Cisco is one of these companies that has spent lots of money on trying to figure out what we should have our senior leaders and managers be focused on. And much of what I can read here is similar to what we've developed in Cisco based on spending lots of money with consultants. So I think this does represent best practice as I see it. One thing that is a challenge is identifying what senior leaders and managers should be working towards is relatively easy. How well we're doing against that is slightly more tricky. And maybe we could have an update at some point about the thinking about how we're going to measure the impact or the performance or the progress towards some of this stuff. Certainly from my experience at Cisco, we've used a lot of research from Marcus Buckingham around impact on high performing teams and team engagement scores. And there's a lot of research at the moment saying things like rating models and 360 models are not particularly useful because they say more about the rater than the ratee. So I think that's something that we need to just develop for, you know, a bit more.
Thank you, Rajiv. Tamina.
Yes, answering a couple of points. I mean, one of the things I would say is that my senior team have an explicit objective around the succession planning, but also developing a more diverse talent pool from within all of their services. So that's something that we are working on very actively. I suppose the other thing is the counterpoint to access to development programmes is the opportunity to put it into practice. So certainly I've talked to people recently who've done everything in their words that they feel they're supposed to. They've done all the training, they've done the coaching, they've done the mentoring. What is it about getting them into an interview situation? What is it about allowing them to, what do they need to demonstrate to enable them to be successful when they're going for roles? And it's as much about giving people the experience and opportunities for different activities within their role as it is around the training and development as well. So I suppose it's making sure we've got a really rounded offer to our staff, particularly from diverse backgrounds, so that they can develop some of the capability and learn how to demonstrate their ability to move into different roles as well. You know, I'm really encouraging my team to work quite tactically around that, where they want to try things out, give people the opportunity to move into a slightly different setting, supporting sideways moves so they can develop a sort of a broader range of experience and ability as well. So I think it is that more rounded offer we also need to be encouraging.
Thank you. More wise words. I've just got one observation. Yeah, firstly, Ash and Jane, I think it's great, a great piece of work. So that's good. And I'm assuming that it subsumes all our previous programs, so we're not layering this on top, but this is now the one we work to. Yeah, and my only observation, which is experience from my past of leading sort of scientific research organisations where you have lots of specialists who are very expert at a narrow specialism, which is sort of a bit like the NHS. Lots of clinical staff are very expert at their thing. Is that the best specialists don't always make the best senior managers, and vice versa. And I think we just need to be careful that we understand as we encourage people to move up that we recognise, the right path for the right person. Because we don't want to get great clinicians being forced to do management jobs because that's the only route they can progress on, and then not be very happy or very good at it, and vice versa. With people, we don't advance just because they're not great clinicians, but actually might have the right skills for senior management. So I think there's another subtlety there along the lines that Tamina has, which I personally have sort of experienced in the past, and I think is worth just bearing in mind. But I think the board is very supportive. And we look forward to hearing updates. So if there's nothing more, we'll let you go. Ash, thank you very much.
Thank you. Thanks, everyone.
Thank you. Goodbye.
In terms of development, the chair has managed to fail the first test, which is to miss out item 8.2, which is the verbal report from Naomi on the FIP. Naomi, did you have anything you wanted to raise before don't embarrass me too much?
I don't, Martin. Much of what we covered back in July has already been covered in this session.
Excellent. Thank you. You're very kind. Okay, audit committee meeting, ready?
Yeah, July audit committee meeting was a relatively standard agenda. The papers are on page 223 of the pack. I think given that it was post the end of the fiscal year, we had the final verbal sign off from E&Y on the audit report, the unqualified opinion they gave. We had the anti-crime TIAA give their final score for the year, which was a green. And then I think the previous audit committee, we'd have the internal auditors give their final rating for the year, which was a 2, which was the highest they've given, in fact, this year. So yeah, happy to take any questions if there are any, but I don't think there's anything to call out.
Very good, very reassuring. Thank you, Rajiv. Okay, Councillor Governor's update. Just briefly, we've of course had a lot of new governors, partly due to elections in local authorities, but also elections of public governors. And I think we've got we've got a full set, I think, but also a pretty enthusiastic set of people, which is really helpful. And I look forward to working with them. And Brian Wilson, who's the lead governor, is doing a very good job in helping encourage governors to play a full part in the trust activities. So really just a very positive report on the governors' meetings at the moment. 8.2 is schedule of meetings. We're changing the schedule slightly, and I guess we'll see how it works. But if you've got any particular problems, I'm sure Julie will be pleased to receive them. Any other business? Date of the next public meeting is the 14th of November, and we'll adopt our normal resolution to exclude the press and... Oh, before I do that, sorry, any questions from observers? Tom or Guy?
No, thank you. Good discussion. Thank you.
Thank you, Tom. Okay, so we adopt the normal resolution to exclude press and public from the remainder of the meeting. as publicity would be prejudicial to the public